Hey, hello there. Well, if we're fortunate, my voice holds, and more importantly, the dog doesn't require any extraordinary attention. We're going to try to do this now. So here's where we were. This is B and this is A for the PowerPoint, and I will have to open it inevitably. Let's see. There we are. And you remember this is what we talked about last time, and I'll get to where. Trouble is, I can't really draw anything with this. I mean, this is just a listing of all the joints, and we talked about origin and insertion. Kind of left it here. This is the characterization of mobile joints. So it depends on how many axes or planes they have. Some people might use the term degrees of freedom. So understand that this is really where they're classified. So we look at the movements themselves. So gliding or sliding, either term applies. Typically, it's square against square. So it only can shift subtly in small amounts. It's not really square, but they're irregularly shaped, relatively flat surfaces, not all of them. And you'll be able to see them better when you start looking at the bones themselves in the laboratory, particularly so with because most of these are with the extremities, and we're going to do that on Monday. So you're going to take a look at the intercarpal and intertarsal joints, and certainly, and I have some specimens where we can at least get an idea what the vertebrae look like together. So they're showing it to you. So even though the overall motion might be moving it from side to side, there's a certain amount. Sort of, you'll see here that because of the shape of the bones, that we'll go into next time. These 8 bones that make up the wrist bones and the spots or the where they meet up, so to speak, with the radius and the ulna. It's almost we call it somewhat of a condyloid joint, which means we can move it, as you can see for the demonstrations here, sort of like moving your hand toward your thumb, towards your pinky in a flat area. And plus, you can do a lot more with it. So it's not really a great illustration. The gliding and sliding, the subtle motions are occurring in here, deep within these series of bones. And I have a nice little clever mnemonic that everybody uses to remember the names of those bones when they're coming up. So, and they're very that's really what gliding and sliding is. Subtle shifts that you might make when you're twisting position in your back. So you're sitting here listening in a desk or a chair or wherever you might be, or in a library, and then all of a sudden you make a subtle motion with your back. Just those little tiny movements. Now, angular movements are very well known. They're principally flexion and extension. And so if you just your elbow is the best way to look at this, increasing or decreasing the angle between the bones. Typically we associate it with sagittal plane motion, particularly knee and elbow and arms and legs. So flexion, decreasing, extension, increase. Not all bones have the capability of hyperextension. As I'll show you when we go over the bones in more detail. For instance, in the elbow, you can't, if you try to hyperextend an elbow, you're going to injure it. You're either going to have soft tissue damage, or you're going to create enough force to be able to effectively, in the word we use is avulse. It's a kind of fracture where you yank a piece of bone off. You're able to avulse or separate a small fragment of what's called the olecranon process, which is on the most proximal portion of the ulna, and frequently injured that way by hyperextension. So we have, and knees are not dissimilar to that. Hyperextending a knee inevitably less in bone damage and more likely in soft tissue damage, that you could fracture a patella with that conceivably. So, and there's a lot of joints that just don't permit that. And typically it's because we call it an osseous stop. Bone hitting bone is principally the reason for that. Now they're showing you here at the neck where it's a little bit different, where in the back and in the neck, hyperextension is not unusual. Certainly not, you don't want it to be excessive because that could certainly be damaging, but it's not unusual. You can extend, if you're thinking flexing, bending, you know, your chin towards your torso, towards your chest, and then your head being erect, being re-extending it, and hyperextending it, and sort of looking up like you're going to look, you saw something on the ceiling, you're taking a good look at something up there. That's there. And the same is true here, as you can see with the model for the back. That's there. But these are single plane motions, and the presumption is that they're sagittal plane, single plane motions. And here you can see it at the knee, flexion and extension. Now, you'll notice they don't demonstrate the hyperextension at the knee area, but it's a little bit different. The upper extremity is a lot more forgiving. And so the way we would describe this is this individual is flexing, reducing the angle, of their arm upon their torso. Okay. So, and extending it, we bring it back down, let's say the neutral position, or even bringing it somewhat farther back. And then finally, hyperextending it, going past a certain level that would be construed probably in alignment with the torso. That's there. So that's the way. So they're flexing their arm upon their torso. When we look at muscles, that's important because we have, for instance, there's two muscles that are mated that do the same thing. Okay, that are rather they're mated, they do opposite things, and we see them in swimming. That's there. And so for those of you who are familiar with it, with muscles and workout, and many of you are, of course, you have the pectoralis major anteriorly that inserts into the upper humerus and pulls it forward, so it flexes the arm, and we're really talking about this portion upon the torso, and then the latissimus dorsi, and a lot of folks work out call them their lats. It's a giant muscle that's mostly arising in the posterior torso area and inserts posteriorly onto the humerus and pulls it back. And so we see those muscles, and swimmers are great to look at. Uh, it's an Olympic year. Next summer is an Olympic summer. And if you want to have some fun and incorporate a little bit of muscle knowledge, that's the time to look at wrestlers, look at swimmers. If you're watching those events, look at the detail on the runners, on the distance runners. It's just fascinating to be able to see, because there are certain sports that really use an amazing amount of muscles. It's a little more difficult to see in the Winter Olympics because they're closed, but a lot of them are form fitting. If you think of cross country skiers or biathletes, where they cross country ski and they shoot, which is itself very interesting. So I don't know if we pay as much attention to a lot of the Olympic sports as we used to. There's always the ones that get the most ink. In the winter, it's hockey and figure skating, and not necessarily as much as the other ones, so they're fun to look at. And the typical ones, and you can see the ones that are on TV, like gymnastics in the summer, and swimming gets a lot of ink, and particularly sports that the U.S. does well in are why they get a greater degree of ink. But they're all just wonderful to look at. You can easily find them that are there. Angular motions, and think of these as frontal plane more than anything else. So if you're standing with your legs wide apart, there we call that abducted. We don't say ad and abducted. It's just like saying afferent and efferent. We always accentuate a letter to make it easy for others to understand. So we abduct away from the midline, and we adduct when we move them toward the midline, typically in the frontal plane, can be arms and legs. And the one I mentioned to you in passing is something that's exclusive. It technically is describing a cone in space. It involves, as you can see, flexion, AD and abduction and extension, all of the limb. So here you'll see. So with your hands at your sides, typically in the anatomical position, they'll be closer down here. So if you're bringing them toward the midline, you're adducting them. You can even hyperadduct them if you can imagine crushing them in front of you, and abducting. In the lower extremity, wide apart would be abducting. Narrowing them, bringing your feet closer together would be adducting. In the feet, it's a little bit different because then we're dealing with transverse plane. You abduct specifically at the joints at the ankle and below, what's called the subtalar joint. You angle your toes outward, that's abducted. So if you see somebody walking with their toes sticking way out, okay, that's an abducted or abducted gait. Where if you see somebody kind of walking pigeon-toed, where the toes point more in, that's an adducted type of a gait. So, and those are things I was trained in doing gait analysis for many, many years. They're there. And there's the circumduction. So effectively, and it's not necessarily the whole hand, an index finger would suffice, just like a big toe. It's just obviously more generous in the upper extremity. And so rotation is just that. And in classic anatomy, we use terms medial and lateral rotation. In sport and in trainers and in athletics, usually the terminology is internal and external. And that's the difference. Orthopedic surgeons will talk about internal and external rotation, and anatomists will talk about medial and lateral rotation. So if you're doing a internship in a sport clinic, for instance, and a lot of students have done they're working with a trainer, they'll look at those kinds of things. So don't be confused when it says internal or external rotation. Same thing they're talking about. And so typically it's a transverse plane motion. on its long axis, whatever that turns out to be. It depends on the position of the limb, either toward or away from the midline. And so we can certainly see that C1 and C2, which we looked at a little bit before, and we're going to look at them again because you're going to get your hands on them in the lab so you can be able to identify them. I want you to be able to do that in the next lab. We're going to first I'll present all the lower extremity bones, and then I want you guys to sit around and start looking at them and be able to identify which is which. And so, okay, rotation about the humerus or the femur. And so you can see it obviously in the C1, C2, and then lateral and medial, just depending on the position. And again, internal and external are terms that were much more commonly used when you analyze these things. Supination and pronation is interesting. So the best way to do this is I can't really demonstrate it particularly well. I suppose I could try. But imagine hold your elbow at a right angle and secure it with your hand. Okay. Now, and this is because there's a specific pivoting joint between the radius and the ulna that permits this. Normally, let's say you're holding your palm up. When you turn it down, you've pronated it. When you're bringing it back upright, you're supinating it. And so it's rotation about, and there's a specific pivoting joint which involves the head of the radius and what's called the radial notch. And we're going to look at that extensively. It's a really important joint. In the foot, if you see somebody walking with a foot that's flattened out versus high arch, so when we use our feet, a lot of times when we weight bear, we will pronate or roll the feet in a little bit. And when we get ready to take the next step, we make the foot more rigid as an aid to propulsion by supinating it or arching it up, might be the way to describe it. I could do it for you, and I probably will when we're in the lab, so you can get an idea about what that is. So if you have problems with your feet and somebody tells you I need to get arch supports, what we call orthoses or orthotic devices, typically, much more commonly, they're used to address a pronatory foot. I can't even tell you how many I made from casts of the foot in a quarter of a century. So now pulling your toes up towards your nose is officially dorsiflexion. So when you're bringing your foot up and shortening the distance, we used to call it flexion, but it was a little confusing. So we call it dorsiflexion, bringing your toes or the top of your foot, let's say going up toward your shin, whereas plantar flexion, stepping on the gas. Okay. And depending on which way it's going. So they're showing you a little bit of that, dorsal and plantar flexion that are there. And these are I just tried to show you a little bit with ankle sprains, inversion and eversion. The most common kinds of sprain that we get is called an inversion sprain. It affects the lateral ligaments on the ankle going from the fibula to the calcaneus and the talus. Okay, so an inversion, imagine the sole of your foot, it's like it's pointing toward the midline. Eversion, much more difficult and typically results in much greater injuries because there's not there's bony blocks, as you'll see when you look at the bones themselves, particularly ones that are assembled and together. And what it does, the eversion, you bring this all up laterally, it just isn't, there's very little excursion. You probably can invert the foot 3 to 4 times as much of a range of motion than you can evert it. And then protraction, retraction are specific about the jaw, and it's facilitated by an anatomical structure that we looked at a little bit, the temporomandibular joint. There's two pairs of muscles, medial and lateral, that go to the pterygoid process. You might remember me pointing those out on the undersurface of the sphenoid bone. And there's muscles that attach to the internal aspect of the mandible called the pterygoids, medial and lateral pterygoids, to each right and left respectively. And they're the ones that move your jaw side to side, front to back. And they do so because the temporomandibular joint, which we'll talk about in this unit, has a little extra cartilaginous disc. And again, it's good news, bad news. Once you add extra things inside of a joint, it gives it a lot more mobility. Good news, bad news, when it's damaged, a lot bigger problems. So there's the inversion and the eversion, protraction and retraction, elevating and depressing, pretty straightforward, and opposing your thumb. The reason you can oppose your thumb is based almost exclusively on a unique joint called a saddle joint, of which there is only one. And so we will look at that. It occurs at the base of the first metacarpal, where it articulates with a bone called the trapezium. Okay. So the metatarsal trapezius articulation is like a saddle shape meeting with a saddle shape on the other side. And that unique structure allows for what looks like a complete ability to circumduct it, but it's not quite there. When you look at it and when we structure it and do it with computer models, it doesn't quite work that way. So there's the thumb opposition, of course. And there you are. So gliding and sliding, flat to flat, flexion and extension, AD and abduction, circumduction, etc., etc. So that brings us to the categorization, and you do need to know an example from each one of these. So plain, it's easy. 3 areas: wrists and ankles, intertarsal, intercarpal joints, and those little facets on the superior and inferior articular processes of vertebrae going either up or down. Those are plain, read that as flat or mostly flat type of joints. And you'll see hinged being and what makes it hinged is the shape looks a bit like what you're going to see condylar, but it's not. And hinge indicates that it really restricts the ability for any degree of rotation. It's almost too close a fit. It doesn't really allow, if you will, some wiggle room. Only 2 pivoting joints, a lot of condylar, 1 saddle, 2 balls, and socket joints. Voila. There you can see they're classified as non-axial motion, flat against flat. Here you can see the hinge, and this what makes the perfect hinge is the humero-ulnar joint. This is called the trochlear process. This is called the trochlear notch, and we'll get to that in lab. So the trochlear notch has a ridge in this somewhat concave surface that fits almost exactly into this little trough in this sort of mated surface. It's not quite saddle shape, but the fact that that ridge and trough are so perfectly mated together, okay, it does not permit. I mean, other than an extra, maybe you can subtly move a little side to side your forearm against that, but more of that motion is coming from the joint that's next to it, which involves the radial head and something that's called the capitulum, which we'll get to. Because this is almost like a round knob against a mushroom cap that allows a lot more of the motion that's there. But this is as much of a pure hinge joint it is. So we consider the elbow pure hinged, as are the interphalangeal joints in your fingers and your toes. They're similarly constructed. So when the 2 knuckles in your fingers are the ones that have that, they're more pure flexion and extension. When you get back to the larger knuckles at the base of your palm, or where you have what we call the metacarpal and phalangeal articulations, or MCPJs, metacarpal phalangeal joints, then you get a little bit more of what's called a condyloid joint, because you can get a rotational component. So with pivoting joints, there's 2. This is the very famous one that I talked about in the elbow. This is the radial head, and it fits inside a rounded, this is all covered in cartilage. This is covered in cartilage. This is called the annular ligament. It's an annular in circles, or an encirclage type of a ligament, and it allows that pronation and supination that's there. So you're going to see a rounded head with a particular kind of sleeve arrangement. And this is somewhat similar, though not identical, certainly, to C1 and C2, to the atlantoaxial articulation in the neck. These are the condyloid ones. So classically, we look at metacarpal phalangeal or metatarsophalangeal. The knee is a modified one because of the presence of the menisci. And effectively, you have an oval articular surface and sort of a concave receptacle surface on the opposite side. And it allows flexion and extension and some degree of add and abduction. So think your index finger. You can move it side to side, whether it's up, whether it's down, whether it's even, so to speak. Doesn't really rotate that much. We get a little rotation because there is a little forgiveness in it, but not as much as you might think. So when you talk about the uniqueness of the index finger, its ability to do that has to do with a particular muscle tendon combination called the extensor indicis proprius. So the proper index finger extender is the one that lets you do a lot of that neat kind of stuff when we point our fingers at people and try to make, a gesture with our fingers or, keyboard and things like that. This is the oddball. Okay. Only one of these. It's a saddle joint. So this is the base of the first metacarpal. This is the trapezium. So you have the trapezium, the distal surface of the trapezium. This is going down to something called the scaphoid. We're going to get to that. Because these are interesting bones, particularly when they get injured. Those short bones are great because they move like crazy, but when they are damaged, they get arthritic, and sometimes their blood supply is completely interrupted, and they effectively, for lack of a better way to express it, die. And we'll talk about that. It's a very interesting disease entity called avascular necrosis, or AVN, because there's so much cartilage, it requires a lot of blood supply from the cancellous bone, and if it fractures through, it's easy comparatively for us to have significant problems with this long term. And almost inevitably, they become either significantly arthritic or flattened and distorted. That's kind of what happens in avascular necrosis. And there's been a lot of very famous athletes who have suffered with this, who has been a career ender, and we'll get to that down the road. So we'll talk about two of the best who ever were. Maybe the best two-sport all-star I have ever seen. And it's not Deion Sanders, though he certainly was in the discussion. Bo Jackson, and many of us purists would say maybe the most unrecognized best center in basketball. Not recognized like Bill Russell or Kareem or Wilt Chamberlain, and maybe not as recognized as the guy from Denver who's been a couple of times the MVP, a very famous guy who's done a lot of announcing and followed Lou Alcindor, who became Kareem Abdul-Jabbar at UCLA during the famous Wooden years, Bill Walton, whose son played basketball, or sons played basketball, one of whom even managed the Lakers, was the head coach of the Lakers. Just we'll get on to it. A lot of historical stuff about that. So this is a saddle, and this is the mate. So imagine you constructed another surface that made it exactly with it. Here's a saddle. It's high in the front, it's high in the back, it's depressed here, it's rounded here, and they fit perfectly together. And because of that, it has an immense amount of abduction and extension and flexion, more so than, say, the condyloid joint. And it allows the opposability that I was talking about. In the ball and socket, there are two. Now, the interesting thing is that when we get to the shoulders, you can see it's not a particularly impressive socket. Whereas the head of the femur is and where it sits in the bone, in the portion of bone referred to as the acetabulum, is a much more impressive socket. And again, this is the same old thing. It's 3-axis movement, so extension, flexion, AB and adduction, internal and external, or medial and lateral rotation. All of those apply. So you can have all of those kinds of things that are there. But as you can see here, the fact that there's a fairly large head on a very limited socket, it has a tremendous amount of mobility, which is the opposite of the hip. Even though it has a lot of mobility, it has much more stability because of the depth of the ball within the socket. That I knew we could do it. So off goes that. B, see A, see you later. We'll just do B. B it is. Voila. So this B is is anatomical because of the joints, and we'll look at a few of them in the time that we have. And it is perhaps a little bit different. At the very end, it talks a lot about arthritis, and I'd rather talk about arthritis to you in lecture next time. So I can, and even in the lab, we'll look a little bit closer at some of the joints with some of the models, which will give you some idea. So there's a lot of, as you can see, there are a lot of diversity in the joints, and some of them are very unique and some are not. I mean, if you're looking at a finger or a toe, they're a relatively straightforward joint. A metatarsal or metacarpal phalangeal joint, there's not a lot special from most of those, maybe save one or two. Maybe when we're talking again, maybe about the thumb and the saddle joint, and the first and the base of your big toe, the first metatarsophalangeal joint. Those are somewhat unique, and because they're unique and interesting, there are more problems when we damage them. This could be a problem because I have a dog who's moving. So let's look at first the TMJ, the temporomandibular joint, a bit at the shoulder, which is you can see pretty well from the illustrations. The elbow, which really has two separate and distinct joints, and if you want to consider the ability for your supination and pronation, a third, the hip, and then probably save the knee for another time because it's so important. By consensus, the knee is the most complicated joint in the body, no question about it. TMJ. Now, I stay away from TMJ because tarso-metatarsal joint is also considered the TMJ, even though it's multiple joints in the foot. And why is that joint important? And we'll get to it when we take a look at the foot. That has another name. It's called Lis Franks. Proper name, capital LIS dash capital FRANCK apostrophe S joint. And if you're familiar with sport and you follow athletes, Lis Frank joint fractures and Lis Frank joints dislocations are never good. And I guess the most recently notable one was an NFL MVP whose career only went in one direction after he damaged his Lis Frank joints, and that was Cam Newton with Carolina Panthers. Just saying. So that's why you're better off, depending on where you're going with your career, not to be careful with initials that can have more than one kind of initial. Okay. Big L's and big R's are lefts and rights. But when you start getting in, there's a lot of acronyms out there. Okay. So be careful with that. And depending on what you're going to do career wise, understand that when you make a notation in a chart, whether you're doing it by hand or nowadays, because we're mostly paperless, doing it electronically, it is memorialized in print. And you'll hear me say this 100 times. The only defense between a professional and potentially a malpractice or liability suit is what you put on the chart. So be very cautious about what you put on the chart and the comments that you make, because they've got to be appropriate, they've got to be exact, and they have to be in a notation where they're not subject to interpretation. Meaning, because you wrote TMJ dislocated, which one? Well, I meant this one. Well, you didn't write that one. See, that you have to understand is the what if I have to defend what I have written in either in an interrogatory, which is a document, or moreover in a deposition, which is a document under sworn testimony. Okay, that's admissible in court. So there's a certain amount of legalities I can share with you because I've been on the wrong end of those and it ain't fun. The jaw joint is a modified hinge joint. It's the mandibular condyle, which articulates with the temporal bone and what's called the mandibular fossa or mandibular notch. Okay. And the anterior portion, where there's a particular tubercle that's there. And that's tubercle is important. And what really gives it its strength is the capsule. And the capsule effectively is incorporated with an extremely strong ligament, which is only on the outside, on either side of the temporomandibular joints, right and left, called the lateral ligament. You should remember that. Elevation and depression, which is basically a hinge motion, and all those gliding, sliding, chewing side to side, front to back. And yes, you see it right here. Most easily dislocated in the joint of the body. What it gives it, its ability to do all those extensive motions, is an articular disc, basically a kind of meniscus, similar to what you have in the knee. The structure is the same. It's made out of fibrocartilage. And that's the good news and the bad news, because if that's damaged, cartilage doesn't heal well. That's why a lot of people have problems with this. They'll open their mouth wide, they go to the dentist, and all of a sudden they can't close it. And it's scary. I've had that happen with me. Because I treat a lot of elderly patients, and when they had maybe this elderly lady had a meniscal tear, I only treated her for 25 years because she was, even at the time when she'd come in the office, to one time she was in a nursing home and treated her children and grandchildren, just to be clear. So understand. Again, all of a sudden she's in my office and she goes, "Oh my God, I can't move my knee. It locked in a treatment chair." God, who knew? We're lucky it finally loosened up. Thankfully, I didn't have to do anything more drastic than just wait until the spasm released. So here you can see it now. Here's this very strong capsule that's there, and here you can see the lateral ligament. That's kind of reinforcing that area where the anterior tubercle. This is the zygomatic arch. We talked about that. This is the temporal process, the zygomatic process of the temporal bone. This is the temporal process of the zygomatic bone. That's the zygomatic arch. That arch, very strong, the extension of your cheekbone, if you want to think of it that way. And here you can see the ligament going down and sort of overlapping. And this is called the ramus, okay, of the mandible on that side. And then you can see the capsule that's there. As we look inside and take that structures away, look what's there. Yeah, you have synovial membranes. We have the condyle itself. We have the fossa. We have cartilage. But right there in the middle, we got an articular disc. Effectively, that deepens the socket, provides the ability for the condyle itself to move in multiple directions. And unfortunately, facilitates its dislocation. And if it's damaged repetitively, significant problems. And they're just showing it to you. Shallow socket of the joint comparatively. That's where the cartilage helps. Almost always dislocates. And the fancy term for dislocate is called luxation. Partial dislocations are subluxations. Total dislocations are complete luxations. So you say subluxed or luxed are the way we would describe them. And so, and it has to be pushed back. And sometimes it's more difficult than you think. A lot of times this requires muscle relaxers. We used to use for these kinds of dislocations, if they were very reluctant, you'd have to inject the area, or at the very least, give the patient some intravenous Valium or similar sort of muscle. Valium acts as a muscle relaxant on all muscles. And so you have to be careful with the person after you give it to them to make sure that you don't let them walk out of the emergency room right away. Ear and face, you've heard all these. Tender, popping sounds. That's one of those sounds. It's a little bit, when I just sort of dismiss sounds with knees and ankles, I don't dismiss them with temporomandibular joints. A lot of people, it's a response to sort of an inaccurate fit. And nowadays, and for the last 50 years, we've been much more attuned to people, the way the occlusion pattern of where their teeth meet their teeth, so to speak. And obviously, a lot of people, to avoid this, will have devices they wear at night, various kinds of molded mouth, if you want to call them a molded mouth guard, or devices that they wear. Sometimes they're associated with, again, some of the devices we see people wear for sleep disorders or snoring disorders. All of that's part of it. So using these sort of molded bite plates is something pretty common, comparatively speaking, and very, very helpful. Pardon me. We're getting near the end of my voice. The glenohumeral, because the part on the scaphoid is called the glenoid fossa, and the humerus was the head of the humerus, was freely moving. We got more motion here than anywhere else, much less stability. We'll look at it in the lab, but this joint is very easily dislocated, and because of the structure, it's typically what's called anterior and inferior. The bone overlaps it in the back, and you have three muscles, three parts of what's called the rotator cuff supporting it in the back. Only one muscle tendon complex in the front is able to support it adequately. So immediately, you have three parts of the rotator cuff, posterior, one anterior. So anterior is inherently more unstable. And there's much more bone posterior and above it than there is below it or in front of it. And so it's a great analogy. It's like if you're a golfer and you put a golf ball on a tee, it's sitting on there, but there's not a whole lot of contact. The capsule itself is not strong. Of all the joints in the body, this is the one where muscles and tendons are the responsible parties for stability, because it's very easy to partially or totally dislocate. And we see it entirely too often. You saw this before when we were talking about tendon sheaths. That's a perfect example of one, and bursal sacs. This is the very famous subacromial, because that's the acromion process. Okay, this is the long head of the biceps tendon. That's the typical tendon sheath that sits in what you're going to talk. You'll see it in lab, something called the intertubercular groove or bicipital groove. And the tendon inserts all the way by a tendon or a little tubercle on top of the glenoid. You have a great amount of articular cartilage on the head, proportionally less on the glenoid. But what you do have, and you can see all the different names of ligaments and things like that. But what you do have more than anything else is you have a labrum. And again, if you follow sport, you'll hear pitchers, sometimes they're out with what's called a labrum tear. And we do the same thing occurs in the hip. The labrum is like a gasket made of fibrocartilage, not unlike menisci, okay, that increase the sort of cup-like structure. It goes from flat to being more cup-like. It's still more like a golf tee than it is a deep socket in the hip. But again, it imparts a certain amount of stability. And by the way, the hip has one also, and those tear as well. There's been a lot of ball players who've had problems with that. So they're showing it to you. It's here. So you can get a look at the bone in this cutaway that's there. There's not, that's the glenoid. There's not a lot to it. So it's called the glenoidal labrum. Fibrocartilaginous rim around the cavity increases the depth of it. And even with that, you're only looking at about 1/3 contact. Not really good. I mean, the whole T thing is probably 1/16 contact, maybe less. You have a certain amount of ligaments that help support it. We'll show you the coracoid process on the scapula. That's part of it. The glenohumeral ligaments. There's ligaments that strengthen the capsule. So soft tissue plays a role. But most importantly, and here you're going to see them. This is the acromion. This is the coracoid, and you'll see that when we look at the bone. You can see a ligament here, but most of the support is on top and behind, not so much in front. And then you have a variety of bursal sacs, and we'll get into the muscles there. I can't do it quite so easily with this particular illustration, but just to show you, there's a variety of ligaments that do play a role. But the muscles we're going to talk about, one, you see the subscapular bursa. The anterior muscle is called subscapularis, and it goes into the head here, and you don't even see the ones on the back. There's 3 of them. Supraspinatus, infraspinatus, and teres minor are the 3 muscles, and you have to know the muscles of the rotator cuff. See how we're looking at now. This is the capsule. They're showing you the glenoid. They're trying to let you think that this sort of a reddish color is the labrum. Actually, I think it's a little bigger than that. But here you're looking from the side. This is posterior. This is the interior. This is the spine of the scapula, and the bulk of the scapula, you can see how much there is above and behind. And very little, here's the coracoid process, way above the joint itself, even though stabilizers come from it. That's why we see the dislocation in this direction so frequently. So they classify that long head of the biceps. The shorter head doesn't, kind of goes up toward that coracoid process. Okay. So the long head going all the way up through that intertubercular groove or sulcus and secures on a tubercle on top of the glenoid is the superstabilizer. And here are the 4 muscles again. The only one's the anterior subscapularis. I'll show you the directions of all of those when we're in the lab. And then you have supraspinatus, infraspinatus, and teres minor. And I'll show you where they derive their names, particularly the supra and infraspinatus and subscapularis. In this case, when I talk about how good looking, healthy cartilage is. So this is in this cadaver, they've opened it up and they're showing you some of the capsular structure. You're getting a little look at the glenoid. You're getting a little look at the labrum. But look at how nice and pristine that cartilage is. That's somebody who never really had big problems. I don't know. There's no way anyone could predict the age, etc., like that. So this is the dislocation. They're weakest anteriorly and inferiorly. The glenoid does not have a lot of contact. So particularly when they're rotated laterally and abducted. So imagine rotating your shoulder assembly your humerus and your shoulder to the outside and abducting it. And that's what I commented on before. It's like making an arm tackle with somebody going by in football. It's pretty easy to mess up a shoulder easily. So they'll try to grip it. And if this season more than any other, it almost seems disproportionate this season. Think of who's playing football, particularly at the professional level. You are years ago, a running back weighed was 200 pounds, a big running back. Now they're two and a quarter, 230, 240. Years ago, they would run, 4.8 in the 40. Now they're under 4.5, 4.4. So you're having an extraordinarily fit athlete and another fit athlete coming to them at warp speed, and they're extraordinarily strong and extraordinary. Now the linebackers used to weigh 200 to 215, even during the Steelers' heyday. Jack Ham weighed 215. Jack Lambert weighed maybe 220. He's 6'4". Jack Ham is 6'2". Hall of Fame players. I mean, it was the exception to have the Dick Butkuses of the world who were 6'3", 250, and because they were run stoppers in the middle of the linebacker. It's a totally changed game from what it used to be. Just to give you an idea, and yes, we do see it from traumatic things. So this is what explains a lot about the problems we see today in professional sports, is the conditioning and the strength and the speed and the size and muscularity of those athletes is just dramatic compared to what it was. And that's the, oops, I'm sure there's a nice animation, but I'll skip it. So pectoralis major, this is the deltoid, this is the biceps brachii. So there's a lot of muscles, and we'll get into them. There, and you see them from the side. The elbow, unique because it's radius and ulna. And really, it's the ulna articulating with the humerus, less so the radius, that accounts for that amazing amount of flexion and extension. So the hinge is the trochlear notch of the ulna articulating with what's called the trochlear surface of the humerus. There is an additional ligament that secures the head of the radius to the ulna in that notch. Again, it's called annular ligament because it encircles it. You have very, very strong side to side ligaments. Any place where long bones come together, you have ligaments. Here, effectively, it's a two bone unit, the radius and the ulna. So laterally, you have the radial collateral ligament, and medially, you have the ulnar collateral ligament. So those two are so important. And if you're watching the game last night on Prime Video, as I was, they had like an animation of the Brock Purdy, the San Francisco's quarterback, how it was different than the typical Tommy John surgery. And maybe I can find the recording and show it to you. What they did was they opened up the ulnar collateral ligament area in sort of a curvilinear incision. That's how we would describe it. And it appeared that they stitched or stapled the tear in the ligament, or reinforced it, or what I would call oversewing it. And then on top of it, they laid some type of material, biocompatible material, to reinforce it, and probably screwed that into the ulna and to the humerus respectively. So it's almost like they augmented it, they reinforced that with that, and obviously sewed it up. And I mean, you know, they're undefeated. He's a pretty good quarterback and throwing the ball pretty well, slinging it around pretty good. So that's the ulnar collateral ligament. That's the one we hear so much about in sport, particularly in baseball and with quarterbacks that are there. And so you can see the way it really is encased. This would be the humerus. This would be the trochlea. Remember, is the trochlea surface, has that little interesting notch in it. Here's the ulna. Powerful tendons. You have the brachialis here, and you have the biceps brachii. There's a big enlargement where they attach on the radial side, not on the ulnar side. You can see here, there's bursal sacs. This is the typical bursal sac. This is the olecranon process. This is where the triceps. This is a giant tendon. You get a lot of bursitis here. That's one of the ones that's very, very common that we see. And so it gives you a pretty good idea of what you're looking at. This coronoid process. That's one of those neat bony block things So it limits the excursion in the realm of flexion, and the olecranon process limits it with regard to extension. That's why we don't see hyperextension. So you get a good idea of the complexity from that kind of an illustration. Here you can see, and the ligaments are very, very strong. They go from what's called epicondyle to epicondyle. Condyles are the are cartilage ones. The epicondyle are raised areas adjacent to, but not covered in cartilage, either along the side of, or just above, or just below, uh, where ligaments attach, and because bones are held together by powerful ligaments that are there. You can see the capsule, which generally you draw a capsule with a little bit more of a distinctive pattern of fibers, ligaments perhaps a little less so. And you can see there's a variety of these that are there. This is this annular ligament. And so you have here the ulna. They don't show you the notch, and the radial head is underneath this. So it allows for the interesting. Now they've cut it away a little bit, so you can perhaps see it a little better. Now we're on the medial epicondyle. This is that very ligament, the ulnar or medial collateral ligament. This is the part where they overshowed it and put the reinforcing from roughly this area. And the medial epicondyle is quite large. We'll get into that when we do muscles. And you can even see bits of ulnar. And a lot of times the ligaments are more than just a string, so to speak, or like a thick shoelace that you see here. You're going to see a lot of them have additional sections, and there's that annular ligament. So you can see it again here. Again, the ulnar ligament, even though this is the most substantial part, there's a portion that goes more inferiorly, and also a section, an additional section, as you can see here. And then maybe we'll make this the last one as my voice finally dies. And this is a much more impressive socket. This is a very large head. You saw the head of the femur. It has a very deep cup-shaped structure that it enters and is held in, called the acetabulum. The acetabulum is formed by all three bones, the ilium, the ischium, and the pubis. It has a good, not a great range of motion, and the socket, and it has its labrum, a substantial rim of fibrocartilage, and it's tough to autoaxins hips dislocate. That's when you see a dislocated hip. There are other injuries to hip, particularly the avascular necrosis, that we'll get to. I'll comment on that. So here you can see the head of the femur. Here you can see the cartilage itself, and look at the extent of the labrum. So you're basically engulfing 2/3. This is an interesting structure. When we look at the femur, you're going to hear me comment on a little indentation in the cartilage in the head where there's blood supply. It's in this what's called the ligament to the head of the femur, or ligamentum teres. Teres means round. So we have teres in a number of ligaments. When I talked about the shoulder, you heard me talk about teres minor. There's a small muscle that's rounded. That's where it derives its name. And so here you have the epiphyseal line where the growth plate was. And so there's called the fovea, an indentation, capitis, head, femur, fovea, capitis, femoris. And within that ligament that enters, that ligamentum teres, is the blood supply to this part of the head of the femur, particularly the underlying cartilage, which gets its blood supply indirectly from the bone underneath it, and maybe a little bit of nourishment from the synovial fluid. So when someone partially dislocates a hip in just the right way, one of the bad things that can occur, most times it's a labral tear, and you can fix those the way you would, to some extent, arthroscopically, the way you would deal with a meniscal tear in the knee, and have a pretty good chance of recovery. Not this bad boy. Because if you rupture that ligament, it interrupts the blood supply and the head deteriorates. And again, the disease is called avascular necrosis. And it causes the cartilage to deteriorate, and to some extent, the head area flattens out. It ended the career of most people would consider, because he was not only was he an all-star football player playing for the Oakland Raiders, he was in 1988. He was the MVP of the All-Star game playing for Kansas City in Varsity American versus National League. His name is Bo Jackson. He is still around. You see him all the time. He is a great athlete, very smart guy. Okay, out of Auburn University. He was maybe the greatest natural. Herschel Walker out of Georgia. You could argue that those were two men who never really had to train. They were just so inherently sculpted and strong that they were just magnificent athletes. And Deion Sanders, now the coach of Colorado, very famously was a two-sport athlete. He played outfield in baseball because he played in Florida State, and then you can make the case he's maybe the best cover cornerback ever. Okay, I mean, so all of those things notwithstanding, but Bo Jackson was hit innocuously on the way out of bounds, not an illegal hit, but he was hit probably shoulder pad, head and shoulder pad into this area of his hip. I think it was the other hip. If I'm thinking it was. I don't know if it was right or left hip. Maybe it was right hip. And he effectively, it was a partial dislocation that caused that ligamentum teres, and he had developed a vascular necrosis. He's had a hip replacement, which is inevitable for folks who suffer from this. And effectively, it would have been a glorious career. So go back and take a look at him. There's a great thing if you look at Bo Jackson and the Boz, B-O-Z, who was played for Oklahoma, and they were big rivals. I mean, Brian Bosworth, who everybody thought was going to be the next great ultimate linebacker. And because he he was a good self-promoter. And you'll watch a play where Bo Jackson literally ran him over all the way out of the end zone. Unbelievable. So the great, those are like Monday Night Football things. And this, I mean, there is that ligament to the head, the ligamentum teres, the blood supply is in there. It's rather substantial. So imagine if that blood supply is interrupted, this all dies. And that's what happened to Bo Jackson. And look at this, look at the size of the head and the size of the socket. It's immense. I will tell you, and I tell everybody the same anecdote. I can't really do the sound, but I'll try. When we had a hip fracture patient, all typically older, and they typically, I think more of them were trans-cervical than anything else. Very common elderly people. This part gives way. Structural weakness, osteoporosis. Procedure we did at the time. Nowadays they would probably do it. Would probably be ready to do. And these were like 90, 80 to 90 years old. We did what was called an Austin Moore prosthesis. It was a head and neck prosthesis. We knew it was going to go. So you literally had to take out the head and in its entirety at the fracture line and ream this out and then insert a head and neck. And you can Google Austin Moore prosthesis. I'm sure they still use them now. And it's because a hip replacement involves replacing the acetabulum and replacing the head and neck assembly. So the fracture line would be here. I'd be holding the retractors along with a couple other guys. whoever the chief orthopedist doing surgery, and he would open it up and isolate the fracture line, and we bend the patient. The patient would inevitably on their side, and we'd have to manipulate the thigh in such a way by strong. We were big guys. Okay. Of some of those residents, I was the small guy. Give you an idea. And all of a sudden, I heard the doctor go, "I need a corkscrew," and I figured we were having wine in the OR, but that was not. So that would have been a nice touch. They were Italian, and a little red would have been good. Okay, I'm thinking Godfather, and I have more stories like that. And out came a sterile instrument that looked like that was a corkscrew. It didn't look like it. It was. He said rather than it had a big handle and you'd screw it right in, just like you would into a cork of a nice bottle of wine. And right, not here, but imagine opening that up and inserting the corkscrew directly in there and pulling with all of his might, 250 pounds, ex-football player for LaSalle in Philadelphia, with all his might. And it made a sound like you popped the cork out as best as I could do it. Honest to goodness, exactly what happened. Stunning. That's how strong it is. So it's mostly ligamentous. You have a lot of reinforcing ligaments as well as the depth of the sockets. This is the one that is not. It's not stabilizing. It's the blood supply that's there. The stability is the depth of the socket. I'm going to show you the ligaments, and that's it. We're going to stop at the knee joint. And thank you for your attention. And I'll distribute this, and I'll send you all, and give it a good listen because there's a lot of information you're going to see again on the exam. Thank you. Not that you didn't, we're doing next week, but and I will record those. I didn't forget. Thank you.